Right, Ben?
We all set, Kathy?
We're all set.
Great.
Okay.
Good morning, everyone. I hope everybody is well. I'd like to call the March meeting of the Connector, the Commonwealth Health Insurance Connector Authority to order. So good morning, everybody. Before we start our meeting, I just want to, and I'm sure others will as well, I just want to acknowledge that today is Faye Ruth's last meeting with us as a member of the Authorities Board. She is leaving 11/99, and I just really want to, aside from the fact it's just been such a privilege to sit on a board with Faye Ruth, I just really want to thank you, Faye Ruth, for always keeping the member spirit experience at the forefront for us, as well as really bringing the voice of organized labor to all of our deliberations. So if I'm going to just pause, I know that Louis will be far more eloquent than I am, but I really just, I think on behalf of all the board members, really want to thank you for your extraordinary service to the Connector and all residents who have health insurance through the Connector. But let me just see if any other board members want to say something. Yep, Nancy.
Thank you, Secretary. Faye Ruth, I've had the opportunity to chat with you a little bit about this, but I just want to echo what the Secretary said. You've been an absolutely wonderful board member, a really calm and steady but fierce representative of workers and families and everyone else who we serve. As I told you, I've learned a tremendous amount being on the board with you. You're careful listening, the questions that you ask, your political savvy, how effectively you advocate. And I'm always just so inspired by your deep commitment to health justice and equity. So I've really enjoyed working with you. I really wish you the best of luck in your new position, and really want to echo the Secretary's thanks for your service on the board.
Anybody else? All right. I mean, there'll be more, I think, when Louis gives the executive director's report, and we'll let Faye Ruth have the last word if she would like on this. All right. So with that, if I may, could I please ask for approval of the minutes of the last meeting?
So moved, Secretary.
Morning, Mark. Thank you.
Morning.
Is there a second?
I'll second that. Good morning, everyone.
Thank you. All right. Are there any additions, revisions, corrections to the minutes? Hearing none, may I believe we will be doing this by roll call, of course. I'm looking forward to when we're not Zooming together. So with that, I will turn it over to Kathy for the roll call. Good morning, Kathy.
Good morning. Good morning, everyone. Martha. She'll need to abstain.
Yes, I'm abstaining.
Okay. Michael.
Yes.
Faye Ruth.
Yes.
Mark.
Good morning, Kathy. Yes.
Good morning, Mark. John.
Abstain.
Keisha.
Abstain.
Dimitri.
Yes. Good morning, Kathy.
Good morning. Secretary.
Good morning. Yes.
Nancy. Good morning.
Morning, Kathy. Yes.
And Rena. Good morning.
Good morning. Yes.
All right. Minutes have passed. So with that, let me turn it over to Louis and the executive director's report.
Good morning, everyone. Our March meeting has a pretty full agenda, so I'm going to aim for brevity. Today, staff will share an overview of our plans for seal of approval for plan year 2023, which includes some significant changes that expand benefits and coverage options to our members over the next 2 years. These changes are a result of careful analysis, public and stakeholder engagement, and reflection on the Health Connector's strategic plan and its health equity priorities. And I am more excited than usual at this year's SOA, which I think really covers some new ground. Next, and further looking ahead to 2023, today we will ask your approval of minimum creditable coverage for next year, as well as the affordability schedule, which includes some modest adjustments to address inflation-driven changes in the federal poverty guidelines. All of these proposed changes come with the backdrop of the learnings we have had during the last 2 open enrollments, as the healthcare landscape has shifted due to COVID-19. This includes changes in our overall enrollment totals, which have decreased as the source of coverage has shifted towards protected Medicaid coverage due to the federal public health emergency, which we now assume to be extended at least through July 15th. We are working with our colleagues at MassHealth to prepare comprehensive system enhancements and outreach programs to ensure everyone who needs new coverage from the marketplace gets it and has a smooth and effective transition from one source of coverage to the next. In the meantime, we see data that shows Massachusetts's overall coverage percentage remains the highest in the nation, and the number of people covered in Massachusetts is the highest ever. Our number of plan selections during open enrollment was 4th among state-based exchanges this year. Member retention remains high at 92%, and about 28,000 new enrollees gained coverage during open enrollment. In the small group realm, today we will seek your approval to continue our joint engagement with the Washington, D.C. Exchange in operating our platform for small businesses. In other news, we are monitoring a national situation that stands to affect Plan Year 2023. Congress has not yet taken action to extend the expanded premium subsidies created by the American Rescue Plan past the end of this calendar year. Well, there has been discussion about making these expanded subsidies longer term or even permanent, as stated in the President's State of the Union address. There are no guarantees. If the expanded premium subsidies were to expire, tens of thousands of low and moderate income Massachusetts residents could expect to see significant premium increases. We also note the possible interaction between these expanded premium supports possibly expiring and the end of the public health emergency, which is an especially important time to make sure that individuals migrating from Medicaid into marketplace coverage have as much help on affordability as possible in order to stay covered. So we continue to closely monitor this situation. On a separate and very upbeat topic, I did want to note that our simple sign-up initiative with the Department of Revenue is active and available to taxpayers in Massachusetts as residents file their state income taxes this spring. By checking a box on their state tax form, uninsured residents can ask the Department of Revenue to share their information with us so that we could work directly with them on getting covered. We hope every uninsured resident takes advantage of this new feature and asks for assistance getting covered. We will be working with those who check the box this spring to get them into the ranks of the insured. And lastly, as the Secretary foretold, I do want to mark today's board meeting as Fay Ruth Fisher's last as a sitting board member, though forever in our hearts. Fay Ruth will be moving on from her post at 1199 SEIU, where she has been for 16 years. She is headed to the Jewish Community Relations Council of Greater Boston, which will be so fortunate to gain her talents. Fay Ruth has been a tremendous contributor to our board, helping us center the member experience and advocating for how we can use our tools as an exchange for as much good as possible. And outside of board meetings has been deeply engaged with staff over the last several years, where there have been opportunities to bridge the connector to the organized labor community or provide health coverage assistance to workers losing jobs or job-based coverage. I'd like to take a pause, if I could, Secretary, and invite any comments Fay Ruth may have.
Yep.
Then I'll wrap.
Yes. I was going to suggest that myself before we got into the agenda. So Fay Ruth.
First, thank you all so much for your kind words.
Nice balloons.
That's what happens when you leave a job. You get balloons. It's wonderful. No, I just wanted to take a moment to say that this has been a tremendous learning experience. I've been deeply appreciative to be on this board, to work with the other board members, to have been appointed by the Attorney General, to be under the steady leadership of Secretary Sutters, who is a role model to a lot of social workers in the macro level world, and deeply appreciative to 1199 for having the confidence to have me here and represent our member voice. I do want to just take a pause to really thank Louis. It has been astounding to watch your steady leadership over the course of my service on the board, with the incredible volatility that you have experienced, and you and your staff have so aptly continued to guide the sort of that true north of ensuring that there's accessible, affordable coverage for everyone in Massachusetts. And I know that with today's substantive agenda, that will continue. And I just want to say thank you to all of you, and thank you for this opportunity to have learned alongside you. And I know that the Connector will be an incredible resource for many, 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 many years to come, and continue to achieve our goal of 100% coverage in Massachusetts.
Thank you, Ruth. And I think I can speak for all of us. We hope that our paths continue to cross. So thank you for all that. All right, so there's never any good segue from sort of heartfelt comments to now the meat of our agenda. So I will turn it back to, I think we're going to start with the health and dental plan preliminary seal of approval. All right, turning it back.
I think Audrey will get us started.
I will. Good morning. We'll do next slide. And Maria's our perfect. Okay, thank you. Good morning, Secretary and members of the board. Staff come before you today to provide an overview of the Health Connector's proposed 2023 seal of approval priorities and approaches. This year's slate of seal of approval related initiatives is chiefly informed by our strategic plan and our health and racial equity objectives. As a reminder, the seal of approval process is the Health Connector's mechanism to set parameters for the health coverage products that will be sold to individuals and small employers obtaining coverage through the Connector for the following plan year, and is also the mechanism used to specify design elements of the Connector Care program for members under 300% of the federal poverty level who qualify. We will provide an overview of the key priorities and changes we are pursuing for 2023, which will be reflected in an RFR issued to the carrier market later this month. In May, we will collect responses from the market. We come back before the board again in July and September for the conditional and final seal of approval discussions and votes respectively, all before we head into the open enrollment period for the 2023 plan year. Today, we will walk through product shelf modifications, key coverage and cost sharing changes and enhancements, quality initiatives, and proposed adjustments to our approach to Connector Care going forward. Next slide, please. Before we dive into the details of the SOA preview, we first wanted to lift up and highlight for the board the specific ways we've made this year's SOA responsive to the Connector's commitment to racial equity and health equity. Informed by research data and stakeholder engagement, Connector staff identified select health equity concerns in the health coverage landscape and designed its 2023 seal of approval to include measures to help address them. This SOA includes value-based insurance design, or VBID, initiatives to address the racially disparate incidence of key chronic conditions and how they relate to inequities in health outcomes, disparities in foregone care due to cost, and disparate burdens associated with medical debt, all of which, if left unaddressed, further exacerbate health status and life expectancy disparities, as well as economic inequities and the persistence of the racial wealth gap. As you'll hear later in the presentation from Maria, we propose to eliminate cost sharing in Connector Care for high-value medications needed for treatment of 4 select chronic conditions disproportionately affecting communities of color, specifically diabetes, asthma, coronary artery disease, and hypertension. We also plan steps to eliminate cost sharing for PCP sick visits in the Connector Care program to ease access to the care setting where many of these chronic conditions are managed. Also in line with our equity objectives, we also plan to require full carrier participation in Connector Care starting in 2024 in order to ensure full choice of the Connector's carrier and provider options for all of the residents we serve, regardless of income or subsidy eligibility, which we will come back to later in the presentation. Additionally, equity-minded components of the SOA will advance behavioral healthcare access in line with the EHS Behavioral Health Roadmap, minimize barriers to gender-affirming care, and ensure meaningful access to care for residents with limited English proficiency. We appreciate the board's support for the Connector proactively using its tools as an exchange to advance health and racial equity in the health coverage landscape, and look forward to diving into these and other SOA initiatives in this presentation. With that, I will hand it over to Sam to describe the 2023 product shelf.
Before you do, Audrey, let me just see if there's any members of the board, just as on an overview, have any comments or questions before we get into the heart of it. Anyone? Hearing none, continue along.
Thank you and good morning. I'll provide an outline of the 2023 product shelf and share details on updates to standard plan designs, small group product offerings, and anticipated carrier changes. As with previous plan year proposals, the Health Connector closely follows federal guidance from the Annual Notice of Benefit and Payment Parameters and the Federal Actuarial Value Calculator. For plan year 2023, we propose to increase the maximum out-of-pocket amounts of standard silver and standard bronze plan designs to the allowed maximum and increase the standard bronze deductible to the minimum creditable coverage maximum. These updates are consistent with our design strategy in previous plan years. Annual updates to the Federal Actuarial Value Calculator necessitate cost-sharing increases to the high gold and high silver designs, while a cost-sharing decrease is available for standard bronze designs and proposed by the Health Connector for this plan year. Our plan design process this year was supported by both existing survey research and a series of member interviews on standard plan design selection, conducted with assistance from our communication research vendor. Lastly, we are monitoring a proposal from the Notice of Benefit and Payment Parameters to increase the actuarial range for low gold plan designs, which would impact the current low gold offering designs by carriers. Moving to the small group shelf, we collected feedback in support of improved PPO plan designs, and new to 2023, we proposed for a carrier's PPO design to mirror an HMO offering on the standard silver, standard high gold, or low gold tiers. We also proposed to expand PPO availability from the one carrier model to both the one carrier and one level choice models. We are also planning for the system implementation of the Tufts and Harvard Pilgrim merger. Preparations will include a collaborative effort between carrier partners and the Health Connector staff to address systems testing, provider network comparisons, notices, communication planning, and other areas. Up next, Maria will provide an overview of new initiatives to improve value, quality, and coverage for 2023 plans.
Thanks. Again, I just don't know if any board members have any comments or questions.
I have a question.
Morning, Rita.
Sam, on the small group offerings, with bringing in PPOs alongside HMO and all of that, have you gotten feedback from the carriers on that? Because that's probably butting up against their normal underwriting guidelines.
Yes, we've received some carrier feedback. There was some favorable feedback, and we will. This requirement doesn't extend to carriers who do not offer PPO, so we're not going to, if they don't offer it already. So we're not going to enforce this on new carriers, but we'll continue to work with carriers to make sure that the plans are stable and the shelf is accessible to members.
Okay.
I have a question, Sam. Yeah, so when we think about a PPO plan design, I understand why it's necessary in that marketplace. When you say the words companion plan, is this going to be structured as an out of area only option? Or are we going to make it, or would it be available for anybody either inside or outside of the Massachusetts marketplace?
No, when we're referring to companion plan, we're referring to the standard design itself. So if a HMO, high gold plan is offered by the carrier on the individual shelf, the PPO would also be that high gold standard design.
And I would just add, Mark, that some carriers do this already. So it's just kind of bringing all of them more in line, because some of them do have non-standard designs that we've heard feedback about that are not particularly valuable when employees and employers are shopping.
Yeah, I think.
And Sam and Maria, as to Mark's in-state versus out-of-state question, do we need to clarify?
Yes, thank you, Louis. The PPO is available for out of state, and that's consistent with how the products are structured now. So this is just about, like Sam was saying, plan design, but it's not representing any change in kind of, area coverage and the actual underlying product structure.
Gotcha. That's very, very helpful to clarify that. And it looks like Mark may have frozen. So I'm sure he'll follow up with you offline.
Yep. Sure. No, happy to whenever he's back. Feel free to interrupt us. But yes, this is about plan design. It's less so kind of a more monumental shift.
Right. Okay. Fair enough. Thank you.
Very helpful. All right. And if Mark unfreezes, we will acknowledge.
Yes, please. Thank you.
All right. Go ahead. Thank you.
Thank you and good morning. As Audrey described earlier, the proposed 2023 seal of approval is focused around addressing areas of health inequities, including improving coverage and alleviating cost sharing for the lowest income members with chronic conditions. In alignment with the EHS Behavioral Health Roadmap, the 2023 SOA encourages carriers to cover recovery coaches and peer specialists. In the Connector Care program, the cost sharing for Tier 1 insulin medication, as well as certain medications for diabetes, hypertension, cardiovascular disease, and asthma, will be reduced to $0 from their current Tier 1 or Tier 2 copay levels. And PCP and mental health outpatient visit copays will also be set to $0 in Connector Care. These zero cost sharing initiatives are unique to the Connector Care program, so they do not impact plans' premiums or actuarial values in the way VBID programs typically would if they were implemented in an unsubsidized plan. The 2023 Seal of Approval recommendations related to behavioral health and substance use disorder are in support of the Behavioral Health Roadmap and reflect responses received in the Health Connector's public request for information process. National and state level data show the disproportionate access to quality behavioral health care and impact of substance use disorders on minority communities. The 2023 Seal of Approval will ensure recovery coaches and peer specialists are covered in all instances in which they are part of a treatment program, and that carriers contract with community behavioral health centers as soon as they are established.
Can I ask a question before you move on? Maybe I should wait till after this slide.
Go ahead, Michael.
You mentioned that this isn't going to affect the premiums because the VBID provisions, I think you're going to talk about some, are unique to Connector Care. What I think you mean is they're funded through a stream that allows us to make these initiatives without doing what otherwise you would have to do. In other words, it's the availability of extra funding that allows us to keep premiums low.
I think I would confirm that these are Connector Care program investments made through the Connector Care Trust Fund, Home Care Trust Fund. And so they are not market-wide mandates. They are investments consistent with the Connector's focus on health equity.
Yeah, and so just to be super clear, I'm super supportive, but the reason I say that is in much of the discussion around the seal of approval, we're making changes to the Connector Care plans because it affects premiums and et cetera. And that's because we're not funding all of those other, if we had money to fill everything in. It would be great to fill everything in. It's just we don't. So we're selectively filling in what we can to get the highest, for lack of a better word, bang for our buck to meet our objectives, related to the disparities and clinical value and things like that. And I think that's what's going on. It just wasn't completely clear to me, so I wanted to say it in public.
Michael.
Thank you. So that's a good transition. The Health Connector chose diabetes, hypertension, cardiovascular disease, and asthma as conditions for $0 medication and connector care because of their prevalence in the overall population and, importantly, their disproportionate prevalence and resulting poor health outcomes in communities of color. Paired with removing copays for selected medications, the Health Connector proposes removing PCP visit copays in the Connector Care program to support chronic disease management. For diabetes, in addition to setting tier 1 insulin to $0, 2 additional non-insulin medications will be covered without cost sharing. For hypertension, cost sharing will be removed for several first-line generic medications. Copays will also be removed for widely prescribed generic medications for coronary artery disease as well as medications to treat a range of severity of asthma. In addition to efforts focused around the chronic conditions described, the 2023 Seal of Approval includes recommendations to improve coverage in other key areas, informed by thoughtful responses to the Health Connector's RFI. The Health Connector plans to work with carriers to learn more about efforts to address maternal health outcome disparities, as well as promote improved care navigation for members seeking trans health and gender affirming care, and work to improve oversight of mental health parity. Staff will undertake these efforts in coordination with the Division of Insurance and will continue to engage with the organizations that provided feedback so the Seal of Approval can continue to advance coverage improvements in future years.
I'm just going to pause and see if anyone has a comment. And Mark, now that you have rejoined, do we need to go back on any part of the presentation so far?
Thank you, Secretary. I apologize for the sudden departure. My internet decided to go down for a moment, so I'm now have my backup operational, so that's always a good thing, right? The good news is we're all skilled at this remote thing now, but I apologize for the inconvenience. I was asking a question or making a point about the PPO. I know you've moved on from that, but essentially I was trying to understand how it was going to be offered to the marketplace, a small group marketplace. That was the nature of my question.
Sure, Mark, and thank you. I'm glad you're back. I will back up to that slide. And we were just sharing that this change does not represent any sort of fundamental shift in PPO offerings or structure. So PPOs right now are offered on Health Connector for Business in only the one carrier employee choice model. So this change will expand that to the one metallic tier choice model as well, which is something that we've discussed with all of the carriers. And the note about the companion plan design, that is just a shift in the type of plan designs that will be permitted for PPOs. And we do have several carriers who currently already have a standard PPO plan design. So this shift will just require that all of them use a standard design. So there's no change in kind of the structure of who the PPO is available to in terms of where they live. It's just kind of a change in shopping availability and tightening of plan design allowances.
Okay, thank you, Maria. I appreciate the explanation.
No, thank you for the question.
Great. Okay. You can go back to the future.
Sorry, I had a question as well.
Yeah, I did too. So.
Okay. Sorry. Yep. Keisha and then Nancy.
Yes, thank you so much, Secretary Sutters. I had a question going back to the behavioral health overview that we got and the options there in terms of the mode of delivery. One of the concerns, obviously, from a member or accessibility is, how they're able to access this. So I was curious if we're going to go into any further detail on how they will be able to get access. Is there telehealth options, or is it just through like community behavioral centers that they'll be able to do this?
Sure. No, thanks, Keisha. I can start, but welcome any input from Audrey as well. So our goal here is just to make sure that carriers are covering these provider types wherever they are available. So whether that's in a treatment program, ultimately in community behavioral health center. So this requirement is really around, whenever those individuals are available, we need to make sure that carriers are covering them. To your comment about telehealth, I'm not sure I have a specific answer to that, but I think overall the answer is that wherever they're available, we need them to be covered.
So Massachusetts law requires, first of all, Massachusetts law permits telebehavioral health. It was passed in 2019. And not only that, but telebehavioral health, which is a broad definition, is also has to be provided and covered at the same as in treatment costs. So in-person and telebehavioral health is the same rates as part of the accessibility. I'm happy to send you the roadmap, which is a blueprint of change. It does not interrupt anyone's existing relationships if they have one. It is for people for whom the front door has not been terribly accessible. In multiple languages, including ASL and the like.
Thank you for that. No, super helpful.
It's not restricting care. In other words, it's meant to really open up the sort of frontier of behavioral health.
No, super helpful, because I think it's a reality as we think of this as a board for accessibility options, where what the wait time is and how they're able to actually get access to care if they only have narrow options to try to seek it. So super helpful.
Thank you. Nancy, now that I have actually fixed my screen so I can actually see people.
Thank you, Secretary. Just two quick questions, Maria. Could you say a little bit more about the gender affirming changes that we're making? That's one. And then completely support all of this. I mean, these are very exciting changes. The exploring ways to enhance oversight of parity. I mean, I think this has been a challenge for a really long time. So do we have some new ideas about how to do that? And I'm smiling particularly at Secretary Sutters. This has been among like the champion of this for so long. So
no, thank you, Nancy. So I'll start with the gender affirming care. And like I mentioned, most of these things came directly from really strong recommendations we received from the public to the RFI. So on gender affirming care, we heard from both advocacy organizations as well as some carriers who do this, that carriers really should be required to have gender affirming care expertise on their staff. So whether that's as a certain designated individual or whether it's, a team of individuals who are particularly skilled and knowledgeable in this area, that it's really important to make sure that those individuals are available to help patients kind of navigate the possibly complex nature of accessing this care. So that is the part about case management. And then the care advisory councils, we do know that a couple of carriers have bodies like this where they convene members from the community, providers, to learn the types of things that kind of need improvements. And so we're looking to carriers who have not yet done that, and in close coordination with the Division of Insurance, because they've been doing a lot of work on this as well, to make sure that carriers are moving in that direction, engaging with the community and providers to make sure that they're hearing those voices and incorporating that into any coverage or care changes.
Yeah, that's great. All those seem like great things. So good. Thank you.
Sure. And on mental health parity, this is definitely something we'll also be working closely with the Division of Insurance on. But we did hear some recommendations about collecting additional information from carriers regarding internal analyses that they are required to conduct on their own mental health parity process. So we're interested in kind of learning more about that, collecting that information, and then using it as a jumping off point in coordination with DOI to see what more we can do in future seals of approval.
Thank you for those the questions, Nancy. I I think it's very important. I really applaud the connectors work on ensuring that our plans have really respectful and processes in place to help individuals who are going through gender affirming care. It is not a linear path that people experience, and it's important that the process be as respectful and affirming, and understanding that it's complicated and people's, pathways are complicated. On parity, having been up on my wall is a 1998 Globe editorial commending the Commonwealth for its first efforts at parity. We are still, we get closer, and it's a reminder that laws and processes continue to need to be reviewed and updated, and as one day we will have true parity in the Commonwealth of Massachusetts. And I think you'll see some things coming from the administration as well very soon about
That's right.
mental health parity as well.
I mean, these are, I think these are.
I failed miserably at this. Apparently.
No, we've made progress, and I think we have to always be focused on the end goal and the progress along the way. I mean, in both of these cases, of course, raise issues of provider expertise and provider capacity as well. And certainly on the gender affirming services, there probably are parts of the state in which those that expertise is less available. So I think it'll be important to kind of examine the intersection between provider networks and these services.
And capacity, yes, and
Yeah.
expertise.
Yeah.
Yep, I'd agree with you. Yep. Okay. All right, folks.
Okay, moving along. So on the quality initiative front, carriers are required to annually report on quality improvement strategies they're undertaking and to identify the area of focus for the project. For 2023, carriers in the federal marketplace will be required to reduce health or healthcare disparities in their QIS initiatives, and the Health Connector plans to adopt the same requirement in the seal of approval. Additionally, for open enrollment 2023, quality star ratings will be incorporated into the online shopping experience, as they are currently housed on a standalone webpage on the Health Connector's website. The Health Connector will work with carriers in advance of implementation to share project updates and expectations. So unless any additional questions on those topics, I'll hand it back to Audrey to discuss proposed Connector Care program changes.
All right,
Great.
let's pause. Any comments? Further questions? All right.
Okay, great. So our last topic here, as staff have previously highlighted for the board, we've continued to see the fact that Connector Care members do not presently have access to the full range of the exchange's carriers as a concern on a few different fronts. The first such issue relates to equitable access to carrier and provider options of a member's choosing, particularly in light of the fact that Connector Care membership includes a greater proportion of enrollees of color compared to the rest of the Connector's membership. This concern is not a commentary on the quality of carriers or networks presently in the Connector Care program, or a commentary on the merits or demerits of narrower or broader provider networks, but rather a commitment to equitable choice. Connector Care currently represents roughly 60% of the state's individual commercial market, and members deserve the opportunity to access and choose from the full spectrum of carrier and network offerings available to higher income peers in the same individual commercial market, even if it means they choose to pay a higher premium for that choice. The spirit of the exchange model, embodied in both state reform and the Affordable Care Act, supports this vision for choice, competition, and a level playing field. In addition to equity concerns, Connector Care has faced in recent years some regional fragility and the risk of minimal or non-existent plan options in particular regions of the state. There are currently a number of areas of the Commonwealth in which almost 20,000 Connector Care enrollees live, where members have only two, and in some cases only one Connector Care carrier choice, even though other carriers offer on-exchange individual market coverage in that region. In addition to the way in which this limits choices for Connector Care eligible members, This makes the program itself concerningly vulnerable to market shifts. To address these issues, the 2023 Seal of Approval will articulate the expectation that all carriers participating on the Health Connector will be expected to also participate in the Connector Care program starting in 2024. Next slide, please. The 2023 Seal of Approval year will be used to implement and prepare for onboarding of new carriers into the Connector Care program and finally effectuating a full exchange presence in Connector Care. While these transitions will require some new functions on the part of the onboarding carriers and the connector itself, these steps will be made easier by the fact that the carriers newly joining Connector Care are already experienced in the exchange. They already offer QHPs, including the silver plans that underlie Connector Care and handle federal premium tax credits for many members and capably comply with the associated ACA rules for subsidy eligible members. New changes will include steps to ensure they are able to accept state premium subsidies and state cost sharing reductions, for example. We look forward to continuing to work with our carriers, stakeholders, and the board to take these steps towards a more equitable marketplace for the years to come, and appreciate the spirit of partnership we all bring to these steps forward.
May I ask a question about this one?
Sure. Go ahead, Nancy.
What are we thinking about? So there's the you must participate, and then there's the what kind of provider network must you propose? So is there any thinking you can share about that?
Sure, it's a great question, and we'll be planning to articulate some of these parameters to the market so there's awareness early and all carriers can plan to that. But it is not our hope or desire to have the new joining carriers replicate a number of narrower networks, which wouldn't necessarily advance the goals we're trying to promote here or solve any of the particular issues that we've identified here. So it is our hope and expectation that what we'll see are a range of the broad network offerings, the broadest commercial network that these carriers offer, so that carriers do newly have that opportunity to choose from a range of network breadths and premium price points and the like. So that's the expectation that we're moving forward with. Okay, great. So with that, we will wrap up this overview and remind the board and the public that we are at the beginning of a nearly year-long process with several stops back in front of the board for preliminary and final seal of approval votes. We will continue to keep you all apprised of progress and welcome any and all questions.
All right, thanks. Any questions? This is information. It's not a vote today. Good? All right.
I mean, bravo. I mean, I think these are just really exciting, wonderful changes that will help improve equity, will help improve health, and are really very innovative. So it's great.
Yeah.
Agreed. I echo what Nancy says. They definitely are impressive what we're trying to do here.
Yeah. Thanks, Keisha. Thanks, Nancy. All right. All right. On to the individual mandate policy items. These ones will take up some votes.
Morning, everyone.
Hello, Marissa.
Let's see. Button is not working.
Something always has to not work during these virtual meetings. So far, we have not had to tell somebody to unmute themselves, but we'll probably have that at some point in this hour and a half.
Very strange. I've never had this particular issue before. Apologies.
Do you need Aaron to drive? Or?
Aaron, if you have it available and are able to share your screen, that might be a good alternative. I'm not sure. I've never had that before.
Absolutely. I'll bring it up now. Apologies, it's not actually showing as an option to share. One moment.
Well, they're working on that. If we move to the open enrollment recap and planning while we work on technology issues, or does this need to flow in the order it is? Oh, here we go. See, I just had to say we were moving on.
Thank you. Erin.
And let me just try to get to slideshow. Apologies.
Okay.
And if not, this is certainly readable.
Yeah, the slideshow is what gave me trouble. Okay, here we go. Great.
Great.
So good morning. So Erin, if you want to, yep, they're perfect. So today I'll walk through 2 updates for 2023 related to the state's individual mandate, the affordability schedule, and deductible limits under minimum creditable coverage standards. I'll review the context and existing methodology for both items, as well as the proposed values for 2023. Next slide. Massachusetts has required adults to maintain health insurance if it's affordable since 2007. For 2014 to 2018, the state mandate existed alongside the federal mandate, but the federal level mandate was effectively repealed beginning in tax year 2019. And this board has policymaking responsibilities for a number of mandate components, including the 2 we'll discuss today, affordability standards and coverage standards. Okay. One more. So the affordability schedule primarily helps taxpayers determine if they owe a penalty or not. It also informs connector care premiums such that connector care plans are deemed affordable, and eligible individuals who fail to enroll would be assessed a penalty unless they receive a hardship exemption. Importantly, the affordability schedule does not impact employers or carriers. It sets no requirement that plans be priced in the affordable ranges, and it does not penalize an employer if an employee who's offered affordable coverage does not enroll. The affordability schedule also works independently of federal subsidy calculations. Next slide. So on this slide, I've tried to visualize for you how the affordability standards and enrollee contributions for connector care interact. So we have a set of affordability standards for individuals that were adopted in 2015. For example, you'll see that individuals with income from 150.1 to 200% of the federal poverty level are considered able to spend 2.9% of their income on premiums in 2022. Based on 2.9% of the range of household incomes associated with that cohort is a range of monthly insurance premiums that individuals would be considered able to afford. So 2.9% of income for individuals earning $19,321 to $25,760 per year results in affordable monthly premiums from $47 to $62. The lowest end of that range is then used as the connector care enrollee contribution for that income bracket, as it's the kind of lowest common denominator that's affordable for everyone in that range. So individuals 150.1 to 200% would qualify for connector care plan type 2B and be guaranteed access to a plan at $47. When we look to the affordability schedules for couples and families, we ensure that a 2-adult household would be considered able to afford 2 connector care premiums. So for couples in that 150 to 200 bracket, the percentage of income in the schedule needs to make sure that a $94 contribution for 2 $47 enrollees is considered affordable. So I hope that helps clarify a little bit about how the affordability schedule and connector care interact, but let me stop for any questions before moving on to how this impacted the 2023 schedule.
Any questions?
So I just have one question if I understand this. The affordability range in the family size is really irrelevant because I'm trying to figure out the math. You took the 47 and doubled it to get to 94. Is that mathematically the same as the 94 that's in the middle column below? Or is it just coincidentally that it worked out that way?
Nope. So we go ahead and try to make that percentage of income for the range something that would allow for a $94 premium, and then it would grow from there to be a little bit higher for individuals at the higher end of that bracket.
Okay, sorry.
No worries. Any other questions? Okay, so Erin, if you could advance. So our general approach to the affordability schedule over the last several years has been to maintain consistent percentages of income that are deemed affordable. Each year, the income in dollars associated with each bracket of the schedule has increased according to updates in the federal poverty guidelines issued by the U.S. Department of Health and Human Services. Put another way, the schedule always has a row for households, 200 to 250% FPL, but the actual incomes of people in that row change based on changes to the poverty guidelines. This year's proposed approach addresses a larger than usual increase in those federal poverty guidelines as they're sensitive to inflation, which we all know has been an issue recently. If we were to use the same percentages of income as we did last year and continue to maintain the link between the schedule and connector care enrollee contributions, we would see enrollee contribution increases of 5.5% over 2022. And we would also have to increase the percentage of income expected of couples and families up to 300% FPL to keep connector care considered affordable for those 2 adult households as a result of that kind of retrofitting that I walked through on the prior slide. To mitigate increases in both the affordability standards for low-income couples and families, as well as those increases in connector care enrollee contributions, we're proposing slight decreases in the affordability standards for individuals, as noted in the table on the left below. And these slight decreases would result in the $1 to $3 increases in connector care enrollee contributions, as shown in the table on the right. So let me stop again for any questions on how that all plays through.
Comments, questions?
I'm going to steal your slide, Marissa, the couple before. I think it explains it really well, so thank you.
Sure, I'm glad to hear that. So if there's no other questions, we can show you the proposed schedules for individuals and then for couples and for families. And if no other questions, we would respectfully request your vote on them.
So before we do that, let me just pause. Any comments, further questions, and the like?
I think this is a really sound thing to do this year when we have such, high increase in the FPLs, and be interesting in light of like some of the inflation number that's coming in right now to think about that, to figure out, did this really have the effect we want? Because we looks like maybe we're going to be in the same position next year as well.
Yep. No, I agree with you, Nancy. Anyone else? All right. If not, may I, we have a vote on the table. Is there a motion?
Moved.
Thank you,
Second.
Michael. Second is Nancy. Any further discussion? If not, Kathy?
I'm here. Okay, Martha,
Yes.
Michael,
Yes.
Fay Ruth,
Yes.
Mark,
Yes.
John,
Yes.
Keisha,
Yes.
Dimitri,
Yes.
Secretary Sutters,
Yes.
Nancy,
Yes.
Rena.
Yes.
Thank you.
All right, the motion carries. Thank you, everyone. Thank you. I want to thank the staff for being creative as always, but really acknowledging, I think as Nancy said, sort of what's sort of happening in the market and in people's experiences. All right.
Okay, so on to part 2, an MCC deductible limits. So as a component of the individual mandate, MCC tells a taxpayer when they're able to check the box to indicate that they had health insurance. Carriers and plan sponsors remain free to design a plan as they see fit, but individuals may choose to enroll or not based on whether the plan counts as coverage at tax time. And as a note, the MCC deductible limits are independent of federal rules around high deductible health plans. The IRS manages those. Next slide. MCC deductible limits were included in the original 2007 regulations at $2,000 for an individual and $4,000 for a family. In 2019, the board voted to add a regulatory provision that would allow MCC deductible limits to increase annually according to the federal premium adjustment percentage that's used for several indexing calculations, including one that already increases the allowed out-of-pocket maximums under MCC. This change addressed the increasing difficulty of designing plans with reasonable cost-sharing requirements outside the deductible while staying within actuarial value constraints under the ACA, as well as an increasing number of plans that were generally robust and market standard, but failed to allow residents to attest to creditable coverage and avoid tax penalties. Next slide. This year, the indexing methodology results in a proposed 2023 MCC deductible limit of $2,850 for an individual and $5,700 for a family, an increase of 3.6% over 2022. Within that, a plan would be able to offer a separate prescription drug deductible of up to $350 for an individual and $700 for a family. While we're sensitive to feedback from the board in prior discussions, as well as literature that suggests that cost sharing, including deductibles, deters both low and high value care and may lead to financial and medical hardship, we felt that the $100 and $200 increases in individual and family deductibles respectively were generally modest, and that an alternative proposal with lower limits for 23 could result in a higher number of state residents being unfairly penalized after enrolling in reasonable coverage. And we continue to seek out data on the impact of deductibles on our members for future analysis. So let me pause there and see if there are any questions on the deductible component.
Comments, questions? Okay, I know. All right. Hearing none, there is a vote on the, I was gonna say the table, but a vote on the screen. If I could ask for a motion to accept.
So moved.
Is there a second, please?
Second.
Okay, we have multiple seconds. Any further comments or questions? If not, I would ask Kathy for the roll call, please.
Okay. Martha,
Yes.
Michael,
Yes.
Ruth,
Yes.
Mark,
Yes.
John,
Yes.
Keisha,
Yes.
Dimitri,
Yes.
Secretary Sutters,
Yes.
Nancy,
Yes.
Rena.
Yes.
Thank you.
Okay, motion carries. Thank you. Thanks for all the hard work, everybody. All right. So we're going to recap 2022 and planning for the end of the federal public health emergency, which we believe will occur in July. Although I've not actually received formal notice, but that seems to be where we are headed and planning for both, I'm sure, on the connector side and the Medicaid side.
So this one seems to be behaving, so I think I could control. So now I'll walk through results from this year's open enrollment period, as well as briefly review some of the preparations we've been making for the end of the federal public health emergency. While the timing for that is unclear, as we've noted, it will result in a large-scale member transition that will be similar to open enrollment in some ways, and that we're planning for collaboratively with Mass Health. Our second pandemic open enrollment period also saw an overall drop in enrollment, as new enrollments haven't been able to surpass terminations with Medicaid coverage protections in place. One notable feature of this year relative to prior years is the doubling of members receiving federal premium subsidies only, which is the result of the subsidy enhancements provided by the American Rescue Plan for 2021 and 2022. We have seen enrollment declines over the course of the pandemic. The Health Connector remains a strong ACA marketplace, ranking 13th among all states for plan selections during this year's open enrollment, and 4th among state-based marketplaces. Although new enrollments at around 28,000 were considerably lower than prior years, strong enrollment prior to the pandemic and high retention rates have contributed to this success. One issue we were watching closely in October when we shared our pre-OE update with you was related to data issues identified during our 2022 eligibility determinations. We found a much higher rate of responses from IRS that our HIC system was not able to use because they were adjusted gross income rather than modified adjusted gross income. And this was the result of 2020 tax returns that were amended to implement provisions of the ARP. Given that the system was looking for modified adjusted gross income and didn't find it, it determined many more people than usual eligible for unsubsidized 2022 benefits as a result of unknown income. After consulting with IRS and CMS and with the help of our systems vendor Optum, we were able in October to use the AGI we received to verify continued eligibility for subsidies for about 46,000 enrollees, which accounts for the steep drop you see on the magenta line in the chart about halfway through. While we did close the gap considerably relative to prior years between this technical fix and heavy communications we did unfortunately still see a higher percentage of members for whom we could not verify their continued subsidy eligibility and who lost subsidies at the end of the year. As I noted, we had about 28,000 members enroll after November 1st for 2022 coverage. Within that, we saw higher than usual enrollments in the ABTC only population, again, reflecting those enhanced subsidies. Generally, the demographics of new members were consistent with prior years, with the exception of this year's new members being slightly older than new members in prior years. However, as in the past, new members tended to be younger than our renewing members. We also invited new members to answer a few questions about their new coverage on a short online survey, and we found that almost 2/3 experienced no gap or less than a month between their last coverage and their new enrollment, which was higher than prior years, consistent with the high levels of health insurance that we're seeing statewide, as Louis noted earlier. With regard to shopping, shopping among renewing members was just lower than in prior years, with 23% of members engaging with their choices in some way. Some just looked while others went through the process and enrolled in a new plan. Many people, though, did come through and just actively confirm their enrollment in their existing plan without making changes. Where we did see changes, we tended to see movement back and forth between silver and bronze, or between BMCAP and Tufts Direct. Another population that we monitored during open enrollment was the group of people who received unemployment for some portion of 2021 and so qualified for enhanced premium and cost sharing subsidies under ARP. The law directed exchanges to provide subsidies to these unemployment recipients as if their income were 150% of the federal poverty level. And at the start of OE, we had over 38,000 members receiving these enhanced subsidies. Among those, about 34,000 renewed their coverage with us, and almost 2/3 of them were determined eligible for connector care this year. About 4,500 members did not renew, and we know that just under half of them, about 1,900, transitioned to Mass Health at the end of the year. Unfortunately, we're not sure where the rest of them went, if they're being covered outside of HICS or not. We saw slightly higher shopping rates in this population compared to the overall renewing population at 26%. So I can just pause there and see if there's any questions on some of these member demographics or enrollment trends.
Jessica, can I ask a related question? So with all of these increases and decreases, do we have data on how many people don't have coverage now?
So there have been some census data released. They've been delayed due to pandemic related delays. Right. I believe we're expecting some additional data, I think next week. But generally the data that we've seen so far suggests kind of lower than we've seen before on insurance rate. So we've seen coverage gains overall as indicated in census data and in some of the enrollment data Chia has been publishing.
Okay, thank you.
Any other questions? Okay, then I'll just briefly touch on contact center. After some initial staffing challenges, the contact center was available for members who needed assistance, though they saw lower call volume relative to prior years, given lower enrollment. The higher call wait times and abandonment rates you see here reflect an average across the whole OE period, but by January, these had stabilized to an average speed to answer of 19 seconds, an abandonment rate of 1.21%, which are well within our service level agreements. This OE also featured a continuation of adjustments made in the outreach space to ensure healthy and safe events. As in prior years, we use signage in priority communities, ethnic media, call-in television programs, and a wide variety of interviews and news stories with navigators. New for this year, we did some tabling at shopping malls, a day of virtual visits to all navigators in January that were broadcast on Facebook Live, and video spots with celebrities like Nancy Kerrigan touting the value of health insurance and encouraging enrollment. So before I move on to PHE, are there any other questions on open enrollment?
Let me just pause. The one thing I would say is we've had on the vaccine side, which today Massachusetts crossed 14 million vaccine doses administered, which is one of those. But we've had good luck with small stores and bodegas and the like in terms of promoting information around vaccine. So I applaud barbershops and the like. I'd also small markets and the like, when they're not very busy with customers, has actually been very successful on the vaccine equity work that we've been working on. And just offer that as a qualitative statement.
Great, thank you.
Any comments, questions? I applaud the hyper local, hyper focused kind of initiative. So thank you for that. Anybody?
My question on that is, that's been successful getting and retaining. It also, two things. It's going to be really important once the emergency goes away to have that same level, I think, of, high touch availability, so we can keep people in coverage as probably many of them are going to transition out of mass health.
So on the mass health side, so we, I don't know if it's technically signed, but it will, if it's not signed, it will be very shortly executed, is a contract with Healthcare for All, which was one of the two organizations that we worked on earlier in the vaccine hesitancy, to really engage in a very strong grassroots, local focused effort to ensure individuals are not scared if they get, a mass health letter around redeterminations, and promoting coverage. Nancy, it's really, and the concept is to really start about 2 months before the redetermination process starts, to just sort of build the messaging, get the messaging start to out, and not before people start to get letters and the like. And like we did in 2015, I want to assure everyone that we will go through this process with the goal of ensuring people maintain healthcare coverage. One, that's first and foremost, that people are treated with the respect and the contact that they need to understand what this process is, and in a way that is culturally appropriate and sensitive, and in the languages that are important, to reach people. So it's a multi-month engagement, and it will start a couple of months before the formal process starts, and really focusing first on individuals who we believe actually do have coverage elsewhere, and to ensure that happens first, right? And then work with individuals who may have more complexities.
Yeah, I mean, it's such an interesting experiment that's going on about what, not that we would have designed it for this reason, but what happens when the administrative requirements to keep your coverage are relaxed, and understanding which of those maybe could be relaxed going forward and which are important to stay in place. And so there are going to be some good lessons for us here, and also probably in most other places as well. And I hope somebody's evaluating that.
I agree with you. I think this is there should be some lessons, right? There should be lessons here. And this is when I'm really deeply appreciative of the strong relationship of Mass Health and the connector. We have so many people with coverage in Massachusetts. But I would agree with you, what are the lessons, and how is it we engage with people to understand what is, pretty complex, right? Health insurance is just not easy to understand, right? So.
Oh no, it's gonna be very complicated to tease apart, and and you more than almost anyone else, Secretary, know we better find some good lessons in all of this.
Hope so.
So yeah.
Right, and to share that with the next administration during transition. So thanks for that. All right, good stuff.
Well, thank you for all of that context. So we just have a couple of slides on this. Just as context, a federal COVID relief package in March 2020 directed states to protect Medicaid coverage for enrollees for the duration of the PHE. And we currently have over 600,000 members who are being protected in Mass Health under those rules. So right now the PHE officially expires on April 16th, but all indications are that it will be extended for at least another 90 days. But we are making sure that we're ready for a mid-July end to the PHE, and the likely enrollment impacts we would start to see in September as members begin to be redetermined out of Mass Health and into connector coverage. Of course, at that point in the year, we would also be preparing for our 2023 coverage renewals, and we're in the process of reviewing any potential interactions between those two processes to make sure that our renewals for Health Connector members and the PHE unwinding are both kind of sound. We've been working very closely with Mass Health and with peers in other states as we prepare for the end of the PHE, looking at everything from system functionality, operations, communications, and reporting. A few items that we're focused on right now are engaging focus groups to test messaging related to coverage transitions and reducing administrative burdens on individuals by expanding the range of applicants whose income would be considered verified by data sources. In April, we'll add a new checkbox to our online application that will allow individuals to authorize the Health Connector to enroll them automatically if they qualify for $0 coverage and don't actively enroll. Mass Health and Health Connector staff have also engaged with Healthcare for All, as the Secretary noted, which was allocated $5 million by the state legislature, in part to provide outreach related to the end of the PHE. So let me pause there and see if there's any questions on the end of PHE planning.
I just have a really quick question about bandwidth in terms of the staffing and being able to deal with all of the eligibility confirmations. Do we feel like we're in a good place in terms of going through that process? I know there were some hiccups, I believe, when we talked in October.
I think the serious hiccups in October and November related most particularly to the staffing with our new vendor for the customer service operations. Those deficiencies have since been remedied, which is really good news. And we do have an active forecasting process with them regarding staffing up for volume. It looks ahead 90 days, but we're beginning the discussions with them about the overall transition at the end of public health emergency. I don't anticipate customer service difficulties at that point. And certainly because we share a joint eligibility system with Mass Health, a lot of problems that other states are facing regarding the transfer of data between Medicaid and exchange operations, we're very fortunately spared from. So it's a really good question, Keisha. We'll keep a close eye on it. Right now, we're not anticipating issues.
And on the Medicaid side, we've been, they have been building up the benefit employment resource specialists, both a permanent increase in staffing as well as a temporary, particularly in the beginning of the process, given how many individuals will need to go through the redetermination process. So we've been building up for additional call center as well as the staffing to flex, which we had done during basically one of the contracts we had during vaccine rollout, kept that in place. And these are, experienced call center staff that we would flex to support this work. And we're currently, yeah.
Thank you both. Thank you.
Yeah, and we're currently working with, our collective bargaining to make sure we have the good resources in place.
So although we do have many unknowns ahead related to the exact end of the public health emergency and the potential expiration of ARP subsidies at the end of the year, we'll continue to plan for the likelihood of a large-scale member transition over the course of 2022 and 2023 and aim to make it as smooth as possible for individuals who need our coverage. And we'll be sure to keep you apprised of further developments in this space as they occur.
Thank you. Thanks. Unlike some other states, I do think the fact that it is one eligibility system in Massachusetts, we had to go through this process. For those of us who remember 2015, when we didn't have, our systems were not quite as strong as they are now. And I think that interconnectedness and the relationship of the strong relationship of Mass Health and the connector, and our goal is always maintain the highest level of health insurance coverage appropriate for the individual and family. And we've been planning for this for a while. We are planning for July. I mean, I think it's difficult to imagine that it would be extended. Not that we have not been surprised by this pandemic before, but I think we're thinking we're heading in that direction. So, and happy to provide updates, certainly, for the board as we sort of stay very close to this. Thank you. All right, and our final item of the meeting for today's agenda, which is a busy agenda, is the Health Connector for Business, of where I've been hearing the ads all over the place.
Excellent.
Right.
Excellent. We like it when people hear the ads.
That's good. Yeah, I can't remember what channel it was, but I was listening on some channel on the radio in the car.
Right.
All right.
Right. Thank you, Secretary Sutters. Good morning, members of the board. Today, I will provide a brief update on the Health Connector for Business's overall support to the small business community and its stable growth during 2021 and 2022 thus far. Additionally, Vicki Coates will be asking the board to approve the new memorandum of understanding with DC Health Benefit Exchange Authority proposed to effectuate on March 15th, 2022. As the board knows, small businesses continue to face unprecedented economic disruption due to the impact of COVID-19 over the past 2 years. The Health Connector has been supportive and flexible since the onset of this disruption by providing payment extensions, resources, and information on how to access affordable coverage through the Health Connector for Business, and continuing to engage brokers and support them while they assist their small business clients in providing the best options to their employees. As mentioned in a previous board meeting late last year, Health Connector for Business reached a milestone in October 2021 by surpassing the 10,000 member mark, reflecting a near doubling of enrollment since 2017. This steady growth in Health Connector for Business membership is particularly notable as it comes at a time when off-exchange small group membership is decreasing. 2 Health Connector for Business surveys were held in the fall of 2021. A Health Connector for Business employer survey revealed that small businesses that shop on the Health Connector for Business are highly satisfied with their experience enrolling on the platform and the benefits of the choice models, with an 86% overall satisfaction result. A Health Connector for Business broker survey revealed that brokers who utilize the Health Connector for Business for their small group clients are also highly satisfied with their experience on the platform and the excellent customer service they receive, with a 75% overall satisfaction result. The other 25% were neither satisfied nor dissatisfied, therefore concluding that no brokers reported being dissatisfied. This is a view of our current membership as of March 1st. Overall, our membership has remained relatively stable. We saw a slight increase in member level terminations, but our retention levels remain at or above 85% on a monthly basis. Our monthly enrollment trend upwards reflects a growth on average at about an additional 100 members a month. This view here is the group count, while the previous slide was the member level count. There has been a 16% increase in groups that have enrolled in the platform since the beginning of 2021, while membership enrollment has increased by 17%. Looking back at our lowest enrollment numbers in July of 2018, Health Connector for Business has seen a 95% increase in membership since then, while groups that were at 1211 in July 2018 have increased by 61%. Given the change in the economic climate, we were expecting little to no growth during the past 15 months. 554 groups and 2,546 members have accounted for new sales on the Health Connector for Business, only slightly lower than originally expected. Many small businesses looking for ways to provide affordable health coverage tailored to the needs of their employees have chosen to offer a choice model plan since the beginning of 2021 into 2022. Choice models, which allow for an employer to select a cost control reference plan while offering their employees choice of benefit level or network access through carrier, account for slightly more than half of the group and membership enrollment. We're pleased to see this unique purchasing model continue to appeal to small employers. Small groups enrolled on the Health Connector for Business come from a very expansive variety of industries, with construction, health services, and business services reflecting the highest membership. This is a view of our current dental membership as of—
Can you go back, please?
Sure. Right here?
Right, yes. So, do you know the size of the businesses? Like how many of these are micro businesses, or less than five or whatever the?
For the industries in particular?
No, general.
Like
what size are the businesses coming into the connector?
Oh, average.
Go back.
Sure. I heard myself. I'm so sorry. The average is. I hear myself. I'm sorry.
It's okay.
The average between 5 to 7.
5 to 7 employees or members?
Enrolled.
Enrolled members. Enrolled members.
Yeah.
Of a business.
Yeah.
So number of employees would be in the 2 to 3 range?
I apologize. I don't have that exact number.
Okay, so
but I think it's
one of the things I would like, I'm sorry, Liz, is the types of employees, number of employees total in these businesses, micros versus whatever the group sizes of employers. I can't, my head's probably still in pandemic mode, so I can't remember the, and then in those, the number of employees who actually sign up.
Yes.
Secretary, if I just look at the data up here, if we just do straight linear math of 2,546 divided by 554, it's five employees, which is not really surprising. It's the small group under market that is going to be best served by the connector for business.
Right. It would be helpful though. I totally agree, Mark. I totally agree. But if you went back another slide with the pie charts,
right?
That I would love personally, and I think others would love to see this broken out by, and I would recommend 1 employee, 2 to 5, 5 to 10, and then like 10 plus.
Yep.
I agree.
Yep.
We would be happy to create the dive on this and can provide it as soon as possible, as well as cover in the next board meeting if you like.
Yeah, you can, in the next update to the board, you don't have to, I think we can wait to the next board meeting or in whatever the regular update is to us, Louis.
Okay.
And Rena, I'm sure like me, you're not surprised that this is attractive to under 10. They don't have this kind of choice in the traditional market. So to be able to offer a defined contribution type of strategy and structure is very attractive to that size segment. So I'm not surprised.
No.
I just want to pipe in real quickly. I was at a Quincy Chamber of Commerce event about 2 weeks ago, and I was impressed in terms of the number of organizations in the room that were participating in the Health Connector. These businesses were ranging in size anywhere from the 2-man operation to about 25 individuals. So the message is starting to get out, and it's starting to resonate with small business owners that there is a product out there that provides them with an option for insurance. Because what a lot of these businesses were doing prior to the Health Connector were really getting into some of the QDP products, and only when they needed the service or the insurance did they discover a lot of the minimal coverage products that they were getting into through church organizations and other did not suffice in meeting the need of their employees. So I want to say kudos to the work that's being done with regard to Health Connector for small businesses. And I want to make sure that we don't lose focus of all of the people that we are helping by having a tool available that they can leverage.
Dimitri, I concur with your thought process. I just wanted to tack on that we've also done a lot of great work with the broker community, and over 94% of the businesses in the Commonwealth use a broker to help them navigate the health insurance market. So it's not a surprise to me that you befriend the advisor who befriends the employer, and then ultimately you get an alignment of, hey, this is an opportunity for us to help these small businesses get some price relief. I would like to ask for a little bit more information on the satisfaction levels. I mean, I think 86% is an okay number. That's a B in school. 75% is a C. I don't really like C's. I like to try and strive for A's. So I know there's no dissatisfaction expressed, but I would like to know if we've probed what satisfaction the brokers are expressing. In other words, if they're saying they're satisfied, in what areas are they saying they're satisfied, and what areas are there opportunities for us to improve the value proposition we provide them, and in turn they provide the small employers.
And I do have that feedback on the brokers and what they replied back on what they were satisfied with. They really highlighted the customer service that they receive. They are very interested in the employee choice models as an offer to their employers, as well as they were very happy with the plans that are offered on the Health Connector for Business. And as you all remember, we did vote on new commissions previously, and they have been very satisfied with the new commission amounts.
So why is it only a B?
So they would still like us to update the platform for ease of service, as well as more communication on the Connect Well program.
Okay. All right.
Thank you for that.
Nope. Great. Thanks, Mark, for asking. Thanks, Rena. Thank you. Okay, you can go to dental now.
Thank you so much. This here is a view of our current dental membership as of March 1st. As a result of both new groups and renewing groups adding dental to their benefit package, dental membership on the Health Connector for Business has seen a 52% increase since January of 2021, with a majority of the membership enrolled in a Delta plan. Here we are into the broker.
Let me just pause. Anything on dental?
I think along the same line, what I would express is the concern that I heard with regard to dental was that the coverage did not necessarily meet the need. A lot of it was minimal coverage, and that folks still had to go outside of the plan to support theirs and their families' dental needs. So if anything, we should take a look in terms of what's being covered with regard to dental, and what, if anything, can be done to more reflect what folks need with regard to dental services.
Thank you, Dimitri. That's great input, and we'll follow up on that.
The challenge, and I don't know anything specifically about this, is always the balance between what people need and what it costs to get that for them, and how we make sure that we have the right offerings there to get them the sort of whatever's being spent is spent on the highest value things. But since I'm not an expert in the nuances of dental coverage, I'll leave it with that vague comment.
Just to piggyback on Dimitri's comment, it'd be interesting to understand if it's on the preventative type services versus, the more expanded services under the dental, because those typically, even in a private plan, is where you have the challenge of the deductible as well as the costs.
And the cap.
Yeah, and the cap, exactly.
This has been a big problem in general, where you cover the very common low cost things, but people that have a real dental need, it can be quite expensive. It can be in the thousands and thousands of dollars if you have a serious dental incident, and many plans don't cover that. But since so few people need it, you often don't have a lot of support to have that coverage, and people would rather have coverage for the less expensive, more common things. And getting that, making it insurance as opposed to just paying for regular things is a challenge in designing dental plans. Since I've already said I'm not an expert, I'll leave it to the staff at the connector to work through. It is, I think, I agree with Dimitri. It's an important question.
Michael, if I could just add in, unlike healthcare where there's an unlimited benefit maximum, there are out-of-pocket maximums, but unlimited benefit maximums. In dental, it's a scheduled benefit. It's a calendar year max, typically $1,500 or $2,000 maybe in a given year. So most things are covered by dental. It's just the dollars don't go very far because of the cap and the benefit.
Right. And a lot of it's not insurance the way we think about insurance. It protects you against the really expensive things, which is essentially the impact of that cap you talked about, Mark.
Thank you all. This is a very helpful set of input, and we'll do a special look at dental benefit as we go forward.
Great. All right.
Let me move forward with the broker engagement part. Brokers are the leading source of new membership. The number of certified brokers and enrollments from brokers have steadily increased throughout 2021 and into 2022. Of the 2,546 new members enrolled during the last 15 months, brokers are responsible for bringing on 1,717 of those members, a 70% share of new membership. The Health Connector for Business program has made it a priority to work collaboratively with the broker community to offer affordable solutions to small businesses across the Commonwealth. We conduct regular monthly trainings for brokers, either refresher trainings for brokers who have sold through us before or trainings for brokers who are new to the platform and program. We also recently introduced a new training series focused on different broker aspects of the Health Connector for Business platform to provide all certified brokers with the knowledge to be able to successfully navigate their portal and provide quality service to their employer groups. The recent trainings were well received with special interest in the Connect Well program and processing renewals. I also just wanted to let you know that I did quickly pull up that information that you had asked before about group size, and 89% of the groups that are currently enrolled have 9 or less employees. So I'm going to take a moment to pause right here for any questions or comments before I turn it over to Vicki for the more significant vote review.
I just want to make a comment that, again, not to state it too many times, we've done a lot of great work with the broker community, paying them commensurate compensation with what's paid in the market was the right thing to do, to compensate them for the great work that they do, and training them and reaching out to them and doing events with them. All these things matter over a period of time. And so I applaud the great work you guys are doing.
And I also want to dovetail on that and say I applaud the work that's being done within the broker community to promote the small group, what the Health Connector policies to the small business community. And I think we need to continue to work with the broker community, as well as continue to enhance the tools that are available to allow businesses to shop for themselves and identify products and tools that are best suited for their needs.
Dimitri, Secretary, can I just tack on one comment to Dimitri's comment and say, I still think there's an opportunity for us to foster teamwork between the broker community and the navigators. I think we're missing an opportunity to bring those two together, because the reality is most brokers don't have the expertise of the Medicaid mass health system. To the extent they could have a navigator to partner with, I think we actually might find even more collaboration and more partnership opportunities.
Okay, we'll take that back. Nancy?
Do we have an equity agenda for our small business products?
I would say, Nancy, that we don't have as developed a one as we do in the individual market, and it's an area of opportunity for us. I do think by the natural focus to micro employers by virtue of the size parameters for businesses participating, I do think we make ourselves available in a very unique way to market actors that lack the heft to do negotiations direct with carriers, and that has some natural equity impacts, but I don't think we have as developed an agenda there, and we can do that.
I mean, I would really encourage us. I mean, it's great to see the growth. I mean, it's still a very small portion of the small group market and a very small proportion of our overall membership. And I think the opportunity we have in small group is to be an innovator, to try things that are not happening naturally in the small group market. And I imagine, building on the really good work that we talked about earlier in the meeting in equity, we could do some innovative things here, which might result in other carriers that are bigger coming along in the same way that we have done in our product offerings and the structures. So I'd really encourage us to think about that part of this market.
Right. And we will take that back because I think there's opportunity here, and we really look forward to folding in small group to the overall strategic agenda.
Great, thanks.
All right.
Good. So good morning. If there's no more questions for Shaitra's portion, I'm going to talk about the MOU and the vote. Shaitra, can you move to the next slide, please? So our current MOU has a 3-year term with 2 automatic 1-year extensions. We're recommending that the board approve an MOU with another 3-year term with 2 automatic 1-year extensions. Either DC Health benefits where the connector can exit the MOU with 90 days notice due to extenuating circumstances, or 9 months notice of non-renewal. The Health Connector for Business budget is prepared and voted on annually by the Connector Board, and this year's budget is included on the following slide for reference. Under the MOU, DC provides a full range of operational and technical support and works closely with the connector regards monitoring and meeting our performance expectations. We have both a senior account manager and a dedicated operational manager from DC for our business. Operational support is provided by a combination of DC staff and their subcontractors. Frontline customer service is through Maximus, and premium billing is handled by NFP Health. Based on daily call stats, weekly call calibration meetings, and continued communication between the connector and DC staff, the call center performance meets or exceeds our standards of 3% or less for abandonment rate and 60 seconds or less for ASA. These are the same standards we expect for our non-group service center. During 2021, the average abandonment rate was at or less than 3% with an average wait time of 39 seconds. Similar to non-group, the DC Tier 2 back office team also receives cases regarding premium billing questions or functions which can't be resolved at point of first call. The DC Tier 2 team averages 43 cases per month with a 12-day turnaround time, and this turnaround time is well within our expectations. Ongoing maintenance of the IT platform is led by DC staff and is managed by their subcontractor Idea Crew. Idea Crew is the same subcontractor who did the original implementation with DC for our business. IT tickets are routinely monitored and discussed with DC, and tickets are at an acceptable low inventory with any escalations handled promptly. The DC EDI team and its function performs at a satisfactory level, and I'm pleased to report we have no complaints from our carriers in the small business area. Overall, from our perspective, the DC team is very responsive and understands our operational and platform requirements well, and we found them to be collaborative partners who work hard to meet the needs of the Health Connector for Business product line. Chaitra, can you move to the next slide? As mentioned, this is the budget for DC that's prepared annually and presented to the Connector Board for a vote in the course of the overall budget preparation and review at our annual meeting, at the annual time in June. So could you move to the next slides, please, Chaitra? I will pause here for a second to see if there's any questions on the MOU or the operational construct that we live in before proceeding to a recommendation for a vote to the Health Connector Board today.
Hi, Vicki. Quick question for you and perhaps Louis. With regard to this service and the costs associated with this service, what would the cost be if this was something that we ourselves were doing in-house?
I don't know, Dimitri, that's a very good question. It's a complex operation with a very complex system platform underneath it. So I don't think the personnel costs, I think, one could economize perhaps on personnel, including development resource. But I do think the prospect of rebuilding the platform or building or acquiring the existing platform and then managing it, I think it's a system operation that I'm reluctant to replicate unless we're really needing to for budgetary or other reasons. So I think the real constraint is the choice around the risk and costs associated with replicating the platform.
Yeah. So I also would emphasize sort of the risk. I think we've learned over time as we try and do some of these things, even some of the best laid plans for these procurements and builds become complicated. So I think my personal view is it seems like this has been really successful. It seems that the DC exchange has built a platform that works very well, although obviously that we could change some things. But I would really need, my personal view is I would really need to see if there's a fiscal or quality problem before wanting to take on that risk of building something ourselves or doing something ourselves. Again, I wouldn't say that's out of the question, but that would be my instinct here.
So,
the question for me arises from whether or not there's a possibility for us to acquire what was already in place, and if we had the resources, if we were to acquire this to sustain operation moving forward, then doing the cost calculus around that to see whether or not that's not a viable solution.
Right. May I, Louis? So I don't want to be the historian because I will leave that to Nancy. But when we went down this path, there's a couple of factors. One was, as Louis mentioned, building our own at that time, and given the experience of where we were in the connectors, evolution was just not feasible. And we were probably also a little bit probably risk averse in creating our own system, given the experience at that time. And DC had a very good, it's not a shelf product because they built it, and they've been refining it over time. I do think, however, Dimitri raises a really important point at this time in this next period. If we extend this, which is 3 years plus an optional 2-year extension, is for someone to do the cost benefit analysis. Has the market evolved? And again, DC's been a terrific, I think, a strong partner. So this is not about DC. This is about the cost effectiveness for the Commonwealth of Massachusetts in the future, I think is what I would say. So it's not a either or. It's at some point when in the annual calendar of the connector, is there a time or someone we ask to just take a look and provide feedback to us? I think is.
And I do want to say there is no desire on my part for us to go pre-2015 with regard to where we were. So the goal is, as we move forward, can we do something that's sustainable, that's supportable, and that's also would be effective for our constituents.
Yeah. No, I think that's a fair.
I just wanted to make one comment about the DC exchange and say they were the only area in the country that actually required small businesses to go onto their exchange. So the good news is that as a result of that requirement, they've got 7-8 years of experience with a very large market, as opposed to the incremental success that we've been having here. So they're going to continue, I would hope, to invest in their technology, Dimitri. So they're a little bit further ahead, but I think the question is right to ask: should we buy it or build it? Right. So that's always a good question to ask.
Right, and it seems to me like we're at that. We're coming.
The secretary froze, or is it me?
I think it's the secretary, Dimitri. There's always that question, though. I see Mark laughing.
Everybody takes a turn in the freezing or dropping zone.
Yeah.
Exactly.
She was making a point, though.
She was. She was.
She was, and I think we've lost, oh, Secretary Sutters is back. Yes?
Looked like she was for a minute.
Yeah, and I think we may have lost Lewis.
I think I'm back, but the internet is a little bit funky today.
You are back, sir.
You are
Good.
back.
But Dimitri, the point is very well taken. And, you know, as a practical matter, the current system is open source, so it is open to evaluation, you know, the relative costs of managing it in-house versus with DC. But I think the bigger point everyone is raising is just we need to examine the cost benefit structure of all of this as we go forward. The growth is something.
Is DC contracting with any other state-based exchanges for this line of business? I mean, is this one of their lines of business now?
I can answer that. As far as I know, Secretary Sutters, we're the only, Nancy, that we're the only one that's entered into this kind of MOU at this time.
Thanks, Vicki.
Are other states not offering that service, or are they doing their own structure to provide that service?
Some folks had other subcontractors they worked with, and other ones got out of this line of business. So because the world had changed with emphasis on it. So, you know, we could go back out and look, but I don't think every health exchange is offering small.
They're not, Vicki. Not every state is. So we could take inventory just to, you know, follow up on Dimitri's question and then see for those that are, what are they doing with regard to their tech platform, which I think is where Dimitri's going. Is that where you're going, Dimitri?
Also looking at that and looking at the opportunity, whether or not if it's something that we were doing for ourselves, we would be able to make it available to others who do not have their own platform. But again, my push is not that we change overnight and try to build our own. My question was, how much is this costing us? And if we're able to buy it, can we support it in-house?
Yeah,
I don't think there have been a lot of good data in the last year or two, but the states that have gone into the small business market, with the exception of DC, which, as Mark said, has given regulatory preference or statutory preference to their exchange in the small group market, in Vermont, which has done the same. Other states have a very, very small membership base.
Yeah.
Nancy, I think piggyback on that, what makes our market different is we're a merged market, right? So we've got some very unique things like you mentioned DC, Vermont, and Massachusetts are the only 3 jurisdictions that have a merged market. So that's another wrinkle, Dimitri, from a administration perspective that would have to be factored into this discussion.
Yes.
Okay.
Yes.
So Lewis and I both got temporarily dropped. I don't think Lewis has been able to get back on yet. So we have a vote on the screen. Is there a motion to accept?
So moved. Oh, Dimitri got it.
All right, so Dimitri gets the first, and I think Mark seconded.
Sure.
Yes.
Given the lively discussion we've had, is there any further discussion to be had? If not, I will ask Kathy for the roll call, please.
Okay. Martha.
Yes.
Michael.
Yes.
Hey, Ruth.
Yes.
Mark.
Yes.
John.
Yes.
Keisha.
Yes.
Dimitri.
Yes.
Secretary Sutters.
Yes.
Nancy.
Yes.
Rena.
Yes.
Thank you.
All right. Thank you. So if there's no more business to come before the board, I would ask for a motion to adjourn. Is there a
So moved.
motion?
So
Thank
moved.
you, Dimitri. All right, is there a second?
Second.
Thank you, Fay Ruth. All right, Kathy.
Okay. Martha,
Yes.
Michael,
Yes.
Fay Ruth,
Yes.
Mark,
Yes.
John,
Yes.
Keisha,
Yes.
Dimitri,
Yes.
Secretary Sutters,
Yes.
Nancy,
Yes.
Rena.
Yes.
All right.
Thank you, everyone.
Thank you. As we end this meeting, again, I just wish Fay Ruth a good journey. Take care, be well, and thank you from all of us for your service on the board.
Thank you.
Thanks,
Also.
everybody.
Thank you.
Bye.
All right. Be well.
Bye.